Good evening, everyone, and welcome to another MuM-PreDiCT Journeys in PPI webinar. We are really pleased this evening to have along Richard Stevens. So Richard has survived 3 cancers and a heart event and continues to live with the longer lasting effects of all these conditions and treatments. He's taken part in lots of different research projects, and including donating tissues and data and all kinds of bits of his body. However, the main reason I asked him to come along to join us this evening is because of his vast experience in patient and public involvement. So he's been involved for well over 20, is it nearly 30 years now, Richard? It's
I'm
been a
in
long
my
time.
30th year, yeah.
30th year, yeah. So he has been at the formation of so many things on both research projects, related boards, and so on. And he is a co-founding editor on research involvement and engagement, which I have to say, that is the first journal I go to whenever I'm looking for PPI inspiration. I'm not just saying that because you're here, Richard. I really do. I read it regularly, and that's the first place I go. So, Richard, I shall turn my camera off and over to you.
Okay, well, thank you for that. And hello, everyone, and Happy New Year to those who weren't in on the call a few minutes ago. I'm now busy juggling controls here to make sure I get the right screen, and I'm hoping you can now see my slides. I'm assuming someone will buzz in and tell me if you can't. There is a frightening list on that first slide of things that I've done or titles that I have. The reality of anything I do is that I start from that bold bit there. I am first and foremost a patient. I have had various conditions, as Rachel explained, and I'm still struggling with some new ones, not the least of which is just getting old. I have to say, throughout all my journeys in public involvement, I have had little or nothing to do with small children, babies, or birth. My mother was a midwife. She used to entertain my brother and I with tales of the deliveries she had made overnight, which means we can now eat anything and neither of us has ever bothered to marry or have kids. I'm just saying cause and effect there. Good luck to all of you and your children. I shall now put up another slide if this works. There we go. Everything we do these days, if we are involved in research, we are asked to think about what sort of impact we're having and how to do it and have it in a good way. So this is the pathway that I've gone through myself, but I've gone through it several times, and you don't necessarily start at the top and work your way down. Sometimes you go into things at a different level. The advice I always give to people is do what you have done. Become part of a group. If you want to get involved in research, if you want to have any influence on anything, it is much better to do it as a team. My personal background is in team sports. That's what I used to do when I was healthy and fit enough. Then find out what it is that fits you best. I was a journalist and a teacher at various points in my life, so what I think I'm best at is speaking and writing, although obviously not every audience agrees with one of those bits. Find a task that you can do. If your strength is, like mine perhaps, in writing, then you may well get involved with patient information materials. If your strength is actually finding out what's going on in people's heads, the psychological impact of whatever condition they're going through, then that's where you come into it. The fourth one is the optional bit, and it's often what we forget to do, which is actually tell people about the study you're involved with, tell people about the research you've been doing, tell other people about the people you've met, get online, go to Facebook, tweet, whatever's your bag, but spread the word that actually research that is supposed to benefit us will be even better research if we get involved in designing and delivering it and shaping it, and then, of course, promoting the results. And I've just put something else on the screen there, which is about that word impact. This is entirely a personal view. The research world is full of people saying involvement should have impact. In the old days, it was called adding value. And in cancer, which is my main background, cancer research, sometimes all we do is say yes to the researchers because they've had a good idea. They seem to know what they're doing in terms of implementing it. And our impact is minimal because we just say, yes, go ahead and do it and come back to us if there are any problems. To me, that's actually adding value. That's telling them to get on with it, but it's not necessarily having impact. It's just a thought that I like to think that whatever I do adds some value, not necessarily has an impact. Many years ago, 2002, a body was formed called the National Cancer Research Institute, which was a really bright idea because it brought together all of the cancer funders. Now, we all know that if people raising money, there's always a different day. There are at least 2, 3 cancer charities trying to get money out of us on television or rattling tins under our noses at the town or outside the shops. But this partnership was actually on how they spent the money. And the idea was to try to coordinate it. So, for example, 15 years ago, there was a big push on lung cancer and also on new scanning equipment, PET scans, for example. So there was a big push on research into what we could use PET scans for. And all of that was coordinated by this huge organization. And they decided from the word go that they would have patients on every committee. And the problem we had at the start was there weren't enough patients to go around. There were too many committees. So those of us who were around in the early days found ourselves sitting on 2, 3, 4 committees. And several people actually gave up their full-time employment in order to do this. Although, of course, they had to be on a decent enough wage to have money in the bank to be able to do that. I was lucky enough that I was one of them. And by 2011, I was doing full-time patient involvement, which is what I still do. I'm hoping while I've been waffling, you've had time to look down there and have a look at how it all worked. These slides will be available afterwards if you need them. So I'm going to bash on. These are some of the things we started to do. And some of them have become commonplace and some of them didn't work. Thank you letters for people who take part in clinical trials. Those have proved very difficult to deliver because the people who actually are in charge of the research aren't supposed to know where the participants live. So you have to have the middleman, the hospital or the GP, and both of them have got more than enough work to do without sending thank you letters to people. That's actually what it boils down to. But arrangements to obtain results of the studies, well, the government has currently passed new legislation, or it's about to, and letting trial participants find the results and tell them how to find the results is part of that legislation. So it's taken us the best part of 20 odd years to get there, but we've got there, not just in cancer, that's across the piece. We managed to get the adult age trial in this country reduced from 18 to 16, but it is still 18 in Europe, which causes problems in things like children's cancer, where in order to get the numbers up for clinical trials, you need more than one country. There's loads of other things on that list. I'm going to be talking about some of them later on. Some you might have come across, such as using patient-to-patient videos to recruit for research. They're very popular now. The NIHR website is full of them. Some of them are studies that no one else had thought of, but we managed to think of and get done. So cancer in prisons. No one had actually looked at what it's like for people in prison to be given a cancer diagnosis and how they get treatment. In a nutshell, it's really, really hard because every time a cancer patient from prison has to go to hospital, they need 2 prison guards to go with them. And they are often handcuffed to the bed while they're having their chemotherapy, in the same way that occasionally it happens that ladies have to give birth while they're handcuffed to things, or at least they used to. Patient-to-patient consenting for tissue banking and talking to people who've just lost someone when their tissue could still be valuable for research. Really tricky areas. But we've made the step forward, and there are 2 or 3 patients in the country who are now trained to do that, and guidance on how to write participant information sheets. I'll put up another slide. There we are. Just to stop me talking for a second. Something we invented was a form of Dragon's Den, and this is where researchers give us a topic in advance. We find them 2 or 3 expert patients and 2 or 3 people with just an interest in the topic, and the researchers come, sit at the table, and we have a chat for an hour. And the room is full of tables. The last few times we did this live, we had over 100 people in the room and about 10 research studies going on each table. The good thing about it was that the NCRI, because it was full of cancer funders, they were quite prepared to fund this, because in the end, this kind of thing actually works out cheaper than funding 10 separate meetings for 10 separate researchers in 10 separate locations. Any burning questions at this point? Right, so I'm so pleased you're all enthusiastic to know a bit more about cancer. Right, so these are the things we have found out and we have done. There is a thing called the Cancer Patient Experience Survey that there used to be one for the UK. There is now one for England, Scotland, Wales, Northern Ireland. So there's 4. This is all about the English one. And after it was run once, we spotted that there was no question in it about research at all. It was all about, were doctors nice to you? Did you know who your nurse was? It's all really important stuff, but there was no question about research. So we planted a question in it for 1 year, and it is still in the survey now. And it is this question: since your diagnosis, has anyone had a discussion with you about research? There's a different range of answers now than there were 10 years ago, but basically we knew from the very first survey that 1 in 3 cancer patients were saying they had had discussions about research. It's a slightly biased sample, because the survey is done with people who were having treatment about 6 months ago. So those who are no longer with us don't get to answer it. So we don't know. But nevertheless, 1 in 3 patients we thought was quite good. And we decided to keep asking this question every year. And the people running the survey, the Department of Health, agreed to do it. And it's now up in the UK, in England, to 44%. Now, I have to say, all sorts of people have had all sorts of ideas to help boost that figure. But I have a strong suspicion that if patients hadn't started asking that question, we might not have had the improvement we've had. And actually, even during COVID, 1 in 5 cancer patients was still being offered the chance to participate in research. And we know from these figures and figures elsewhere that in cancer, it's not the same with every condition, but in cancer, 2 out of 3 patients, if they are asked, do you want to take part in research, they will say yes. They're not always eligible for it, but they will have a go. We also know from surveys like this that the cancer patients who aren't asked want to be asked. They may say no, they may not be eligible, but actually in cancer, we want to ask. We seem to have got this collective idea that all cancer treatments are based on research that other patients have volunteered for before us. And we are quite happy to consider the idea of volunteering, but the system still isn't approaching over half the cancer patients in the UK. So there's still a lot to do, but nevertheless, over whatever it is, 10, 15 years, it is slowly going up and getting better. There are all sorts of qualifications to add, which are on that slide. But in the interest of time, I'm going to try to bash on a little. There we go. We also discovered that if you do have a conversation about research, you are more likely to be satisfied with your overall care. Maybe you just feel people are taking more notice of you. And if you actually participate in research, you definitely are more likely to report satisfaction with your overall care. Maybe you feel better about it. Maybe people are doing quality of life surveys with a clinical trial. Who knows? We don't know what the reason is, but nevertheless, there is a message there for the health service, which actually patients are more likely to be satisfied if they are asked to contribute to the good of other patients by contributing to research. Really interesting finding, I think. Also along the bottom there, that's how researchers should present results. Forget all these complicated graphs and stuff, just have smiley faces, good, bad, or indifferent. There you go. That's our suggestion to researchers. And having said that, there's a graph. This was something else we got involved with. Cancer data in the UK is really, really good. We are one of the best countries in the world at registering cancer patients. 300,000 diagnoses every year, new cancer patients, and only about 30 people every year. It's a minuscule number opt out of cancer registration. And the good thing about cancer registration is that it is linked to all your other health records, unless you've opted out of sharing them. So what we asked was, are hospitals that do research better hospitals? And the answer is, well, they get better outcomes. We knew from the survey that that the patients are more satisfied, but actually, are we getting better outcomes? Colorectal cancer is a huge cancer, 40,000 patients in the year in 2016. 14 years worth of records were looked at. Hospitals were divided into hospitals that do no research, some research, lots of research. If you go to a research-rich hospital with colorectal cancer, after 5 years, your chances of still being alive are 2.5% better than if you go to a hospital that doesn't do research. And 2.5% of colorectal cancer patients then was 1,000 people every year and their families, so their families don't lose someone. Problem is, of course, that not all of us can go to research-rich hospitals because the ambulances would be queuing down to the next town, never mind just round the block like they are now. So the message really is for the health service is to turn every hospital into a research-rich hospital. You'd improve outcomes and you'd improve the patient experience. Bingo, easy. Dear Wes, get on with it. Any burning questions on those little bits? Okay, so a little bit about something else that patients and indeed carers can get involved with, which is the James Lind Alliance Priority Setting Partnerships, and that's the web page you go on to. We have done, well, there are several in cancer, but essentially this is a process that takes about 2 years and will at some point involve thousands of people. But this is where you get to identify the research questions that patients, carers, and frontline clinical staff, not researchers, frontline staff, think they still don't know the answers. Research questions that are really important for the trenches, the front line, our hospitals, our services. And you go through it all, find the questions that haven't been answered, and then at the end of it, you come out with a top 10. It's always a top 10. Almost always there are more questions than that, but you go through it. It's really interesting. It's really involved, but at the end, what you've got is a set of priorities. And because this is such a careful, thought through process, research funders tend to look at these priority setting partnerships, and they actually give grants for people who can pitch a research idea that meets one of the priorities. So this is a great way of getting the research that we fund. It's our money that we give to charities. It's our money that we pay in tax and national insurance. So it's our funding that funds the research, but we can also get it to shape the questions that we want answered. And if you go on that website, you'll find there are over 200 priority setting partnerships in various countries across the world. Some really interesting stuff from A all the way down almost to Z. Cancer is the most popular condition, but there's loads of stuff on there. And actually, it's often where children's diseases and maternity conditions are flagged up. But I will let you explore that at your leisure. Just to briefly go through these, as I said, they're on slides that you will get. The Living with and Beyond Cancer identified, these are the top 10. For me, it's the ones that aren't in the top 10 that are most interesting. Yeah, lifestyle changes, how can we predict who's going to have long-term effects, like keeling over with a heart attack 10 years after you've had certain drugs? What's the best models for delivering care? What causes fatigue, psychological impacts? Many cancer patients do suffer from depression, but curiously, it's after they've been given the all clear, not while they're having treatment. And it's almost as if someone's kicked away the ladder and you're told, well, now you can have your normal life back. And you just think, but suppose the cancer comes back. What the hell am I supposed to do with a normal life after what I've been through, etc.? So there's lots of interesting stuff. The other questions, which are shown somewhere on the website, are things like, does it make a difference for people who are living alone? What happens if you're a very spiritual person and you lose your faith? And that came up because a vicar actually said, I've got cancer, I don't believe in God anymore. He didn't put it that simply, but we suddenly thought, well, there's an interesting one. So that's that. That's the James Lind Alliance Priority Setting Partnerships, 200 examples of them available on the website. Any burning questions now? Right, the next bit is something that Rachel has already mentioned, the journal. There is a journal of research involvement and engagement, and like all academic journals, it is full of academic articles. I recommend that you don't read them unless you're really into academic articles, because every single one of them has a plain language summary, because the journal does not accept submissions unless they've got a plain language summary. If a submission comes in without a plain language summary, it goes straight back to the researcher saying, we're not looking at it until you do a plain language summary, mate. And they do. Some of them are plainer than others, it must be said. Anyway, this is a journal where it is the only health research journal in the world which has a patient editor-in-chief. It has patients involved throughout, patient reviewers, patient assistant editors, and indeed patient co-authors, as it says there, 45% currently of the papers have patient or community co-authors. As a comparison, across all health research journals in the world, the proportion of papers authored by or co-authored by patients is less than 0.1%. So this journal is wiping the floor with everybody else. It is, of course, about involvement and engagement rather than health, but nevertheless, it's setting a very good example. Let's see if I can get the next slide up. There we go. Oh, that's everything I've just told you. Probably should reverse those slides. And this is an interesting slide just for interest. This shows where the lead authors of papers over the past 3 years have come from. And which means there is some sort of involvement or engagement going on in all of these countries. I think Australia, United States, Canada, UK, you might expect. Kazakhstan is there. We have had only one paper from Kazakhstan, but nevertheless, we have had the one paper. Interestingly enough, that also involved Bulgaria and Romania, I think, but the lead author was from Kazakhstan. So there is a lot of involvement and engagement going on around the world, and it's lovely to see, including 1 or 2 countries where engaging citizens in things is not something that they might normally do. And Pakistan is there. We've had one paper from Pakistan about 3 months ago, and it is the only patient group looking at research clinical trials in Pakistan. It's at Karachi University. But everyone has to start somewhere. Some papers, if you wanted to look at them, you can just browse through the journal, of course, picking out what you fancy, pump in maternity or some other keyword, see what comes up. The bottom one there in the light blue was published 3 days ago, and I thought that was pretty timely for this particular session, so I quickly added it to the slide. So when you get the chance, you might want to have a look at that one as a start. There we go. Any burning questions about the journal? Well, thank you all for laughing hysterically at those jokes. Now we're back recording again. So the next slide is about a unique patient movement. useMYdata is a group of patients and carers dedicated to the use of healthcare data in research. It is the only group that so far we've discovered anywhere in the world which is focused on healthcare data as opposed to a particular health condition or process or treatment. It's about health data and how it can be used, as it says, to support medical research. And their mission is to be a trusted voice for patients and the public, admittedly in the UK, but it would be nice to think it's global. And one of the things they have done is this. They've invented a patient data citation. And the patient data citation says this work uses data provided by patients and collected by the NHS as part of their care and support. And what we're trying to do at useMYdata is persuade every researcher in the country to use that patient data citation in their journal papers or on their posters. And when we go to conferences, if we see a poster that has used NHS patient data and has not said that, in other words, they're not saying thank you to us, the patients, because it's our data, we peel off from this piece of paper, which you can barely see, we peel off one of these stickers, which has that citation on it, and we stick it on their poster. So far, they will learn. Every student researcher in the University of Leeds Medical School and their Centre for Doctoral Training on AI in Healthcare, every one of those students is now using that phrase on their posters. The young learn quickly. This is what we found about why and how patients and the public, not just the people in useMYdata, but beyond that, want data to be used, and the conditions about anonymizing it or pseudonymizing it. Store it as carefully as you can. Don't send it to people. Researchers who want to use it have to come in so you can see what they're up to and you know what they're looking at. And every committee that allows access to our data should have one of us, a patient representative, sitting on it. And the NHS and healthcare trusts should be publishing who is using their data and what for. And mostly it's for completely innocent purposes, academic research or improving the healthcare services, in which case, why aren't they telling us? It's daft not to. And when they do talk about data, in the bottom left there is a genuine conversation which took place at a meeting where a researcher said NHS data is like a reference library, and one of my colleagues put up her hand and said, "What's a reference library?" He said, "Well, it's like a normal library, but you can't take the books out." And she said, "Well, what's the point of that?" Anyway, we decided you needed a better diagram. So health data is like clothing in an Oxfam shop. It's something we give, but all the name tags are taken out. The analogy falls down after that, but nevertheless, it does create a nice slide. Any burning questions about that? And once again, what a lovely break that was. Very funny. This is the involved diagram about what the research cycle is, and it's fairly old and it's still good. It's still solid. It still describes how research goes round. But increasingly, I think there are things not directly mentioned here where patients can get involved, or patients or anybody with a healthcare condition, lived condition, whatever you want to call it, can get involved. And I've mentioned a few already. One of the most obvious ones is fundraising. It is our money going into research, and we keep pumping money into it. The worth of health research charities in the UK is way ahead of most other countries, especially in cancer. Cancer Research UK is a massive spender in cancer research. It's well over £400 million a year. What we're good at when we do get involved, designing and managing research, what we're really good at is recruiting people, explaining stuff clearly so that people think, actually, yeah, I'm okay with doing this. Retaining people, what makes people stay on a trial through the most difficult situations. And compliance, how can we encourage our fellow patients to actually do what the doctors tell us? And we're all citizen scientists, or at least many of us are. In about 2 weeks' time, there are going to be hundreds of thousands, if not millions of people in this country staring out of their windows, counting the birds landing in their garden and trying to identify what they are. That is a national piece of citizen science where we are all doing the research ourselves. We are contributing data to a research project. That's not the only example. There's loads of them on the internet. We also blog and lobby these days. Patients have opinions and we're getting better at expressing them. Facebook groups, of course, are absolutely full of them, but the blogging and the lobbying are longer. I suppose they've replaced the writing the angry letter to the Daily Telegraph. Service delivery, we're getting really into, and we like to know what works. In other words, if we're improving our healthcare services, what's the evidence behind it? Why do some hospitals do things one way? Why do they do it some way, a different way somewhere else? How quickly are people discharged from hospital? Is it to do with their health, or is it to do with the pressures on the beds? What happens to them? How many of them have to go back to hospital? And can we feed all that data into an artificial intelligence machine to try to predict who is really safe to go home and who isn't? And policy, as I mentioned earlier, especially in cancer, but it's now happening more and more in other diseases, as patients are more involved in providing data for evidence, in shaping research studies to form the evidence, so we are persuading policymakers, this is the evidence. This is about health. This is not about your political beliefs as to what's good and what's bad. This is about improving the health of the nation, which benefits everybody of all political persuasions. And we're getting stuck into that. But that is also involvement. That is simply using the research to make the change. So galloping through these, what public involvement can do, it makes research more relevant to patients, which means it's more likely to recruit and retain. It helps to define what's acceptable to participants. So just how many extra tests will you put up with when they're nothing to do with your own personal care? We can improve the process of informed consent and making sure people actually do understand. The word informed there does mean that you have understood it, not just that someone has told you about it. Improving the experience of participating in research, which probably goes back to the Cancer Patient Experience Survey and the fact that people do feel good about it. But we also want families to feel good about it, especially if they're the ones ferrying you to and from hospital. Improving communications of findings to participants and the wider public. This is not science about molecules and cellular biology. This is actually about, can we help patients to live longer or cope with this condition? And helping to make research a routine option in healthcare pathways. And that means in all hospitals, in all GP surgeries. And I was just going to talk a little bit about this, which is purely a personal view. After 30 years in research, I have finally got to stick with a study all the way through, or at least all the way through so far. This is a primary care study about cellulitis, which is basically an infection of legs or arms when your limb just swells up and goes bright red, and then your skin goes all scaly and falls off. That's effectively it. And it's a study about what's the best dose of antibiotics. Is it 5 days or 7 days? So I was involved in it because I had cellulitis. I was involved in the design, part of which I started to think about while I was still in hospital having treatment. I helped write the application. I helped do the participant information. I go to the monthly meetings. We've had huge recruitment challenges. My co-PPI person, Graham, has come up with a lot more ideas than I have about how to improve it, but it is patient ideas which have gone into it, which have helped improve the recruitment. And it's looking to finish its early stage later this year, and if, fingers crossed, if we carry on recruiting the way we have done, that will justify rolling the thing out nationally, and then we will actually have the answer to, do we really need to give people 7 days antibiotics, or is 5 enough, thus saving vast amounts of money for the NHS and stopping people building up antibiotic resistance? Any burning questions about anything I've said at all?